Hey everybody, welcome to PerfWeb. So today is another day like a few days ago where we don't have Joe here. He's again out at clinical sites doing clinical things. So you are stuck with me hosting and I got Vicky Carlisle here co-hosting. Um, so yeah, let's I guess get the show started. I'm gonna try to do some of the things Joe does at the beginning, something that I didn't do last time, and let's hope that I don't get yelled at. All right, so very first thing, Dave here will pop up. Yep, the contact us email. You guys can write the email. Joe, as he states many times, he responds to all the emails that you send. It might take him a day or two, whatever, to respond, but he does respond to all the emails. So any questions, any concerns, any comments, anything, just email the email that's provided on the screen below. Now we have the Chiron crawl, which also has the information down below. It's that little scrolling bar of text going across our screens. That also will have a lot of information, so, you know, take a look at that. That will have everything you need to do. The MediWeb app, which Joe likes to bring up regularly. This app is great, and I do use it on a daily basis. I know Joe says that a lot, but I actually do. I'm lazy. I don't like to calculate flows, and I know how to calculate it. I just don't like doing it. So I don't like calculating the BSA, you know, on my pump cases. Again, I don't have time like that. So I do like and I do appreciate that it has all those calculations built into it. It's also got the more advanced calculations, the harder ones, DO2, DO2I, stuff like that. It's got nurse calculations, ECMO specialist calculations. Pretty much, it's got a button for everything. So check it out. It's sold on Google, the Google Play Store. It's on the Apple App Store. It's $2.99. Give it a whirl. Joe wants to sell 1 million of them. I'm pretty sure you heard him say that. He needs that to retire. Lastly, we got our PerfWeb podcast right there, or right there. There we go, right? That's the one right there. Had to look at the screen, sorry. So yeah, check out our PerfWeb podcast. You will be able to access all of these live streaming events that we have on our podcast. Check us out on YouTube. We're also on YouTube. If you're not already on it, check us out on it. Like us, subscribe us, tweet about us, put us on any type of social media that you got. We will be thankful and happy. So, what are we doing here today? Well, I am going to turn it over to Vicky. Vicky is, again, our resident ECMO expert. It's what she does. She's also an ICU queen. I've seen her work.
Well, hello. Yes, my name is Vicky Carlisle. A lot of you have probably seen me on here before. I am a CVICU critical care nurse, but I am here today talking from the perspective of the adult ECMO specialist. That is the role that I was performing for this particular topic. So we're going to be talking today about massive transfusion protocol on the ECMO patient and kind of the story that goes along with that. So bleeding on ECMO, well, the rate of any bleeding during ECMO is reported to be as high as 29%, with a 10% risk of major bleeding and a 4 to 10% risk of intracranial hemorrhage. Increased risk mostly because most of our patients on ECMO are going to be critically ill, so you're going to have sepsis-induced coagulopathies in place already, perhaps acute liver injury exacerbating your coagulopathy. Even things like hypothermia or acidosis can exacerbate bleeding. Or you can have a patient that's a post-operative period after, say, a major surgery. This also puts you at a heightened risk for bleeding complications. Secondly, the ECMO circuit and pump themselves impair multiple innate primary and secondary hemostatic mechanisms. So inflammation associated with ECMO definitely disrupts the coagulation process, which leads to increased bleeding risk. You also have dilution of your clotting factors. This can be partly because of your ECMO prime after initiation. There's also something called a Brauman effect, which is really adsorption of your clotting proteins on the surface of your ECMO circuit. It's kind of like a competition for who can get there first. Typically, it's going to be fibrinogen that's going to initially surface coat, which in turn later you're going to have like albumin.
You see those yellow strands, and you see it. Yeah,
you definitely do.
You definitely see it.
And then eventually that'll be replaced with things like albumin and factor VIII. All of these things, adsorption, but it creates a diluted effect for what you have circulating in your actual blood. Let's see, platelet dysfunction. For sure, ECMO causes platelets to malfunction. It reduces their ability to clot effectively. This is kind of because of what's called an acquired von Willebrand syndrome. Von Willebrand factor is kind of like a long string that attaches your platelet to your cellular wall where there's a site of damage. And so when it's not functioning properly, you have trouble for your platelets to make the clots where they're needed. This can partly be because of the high shearing forces in the ECMO circuit. You go from anywhere like negative 300 on the drainage side to
easily that much,
positive side 300 plus. So that's some pretty high shearing forces that von Willebrand factor has to tolerate, and it often leaves them misshapen. They're normally very long chains, which makes them more effective, and the misshapen ones are shorter.
Yeah, they get basically cut and sliced up.
Which is kind of what this chart here is showing. Right. The loss of those long von Willebrand factors. And of course, this is important for that platelet aggregation and blood clotting because it also binds with factor VIII, so it affects the clotting in the actual circulating blood volume as well as platelet. Prone for causing like respiratory bleeding, mucosal bleeding, and puncture sites, and particularly important for us ECMO people. We have bleeding at the insertion sites almost every time.
Yeah, it's so common.
Yes. Let's see. Anticoagulation, for sure. Because this high inflammatory response starts this whole cascade with bleeding versus clotting. It's a balancing act that we're trying to do every time, which can lead to clotting in the ECMO oxygenator, can lead to oxygenator changeout. Sometimes your patients can't tolerate that no matter how quick you are.
Exactly, yeah.
And so a lot of times to combat this risk of clotting, of course, we have systemic heparin or systemic anticoagulation that we use, most common being the unfractionated heparin.
It's like an ugly loop that we get stuck in, and we can't do nothing about it because we got to protect the oxygenator, right? We can't just let them clot up the oxygenator because that could kill them. Correct. And so, it's just a nasty business.
And just clots being blown back to the patient.
Exactly, and then now you have emboli going and causing problems, strokes, this, that, whatever.
For sure, which is the second most common complication of ECMO. So definitely important, where we may go more frequently on VV ECMO without systemic anticoagulation, something that I've seen kind of start around COVID time.
Yeah.
But VA ECMO, definitely we like to have some anticoagulation on board.
So VA ECMO and VV ECMO, let me just briefly explain that for them. For the ones that might have not tuned in to any ECMO lectures that we've had in the past before, again, I'm just trying to give us some, a ground to stand on here. For those that know, they know. ECMO basically has, it has more than these two types. These are the two main types. It has many different types. But we're going to talk about these two for now. There's VA and VV, right? VA ECMO is veno-arterial and VV is veno-venous. So the difference in the two has to do with the support that we're providing the patient. VA ECMO, basically what we're doing is providing circulatory support and pulmonary support. So basically we're having to do the job of the heart and the lungs, because both are either not functioning, or they are functioning but they're diseased in some kind of way.
Yes.
Either pneumonia or heart failure or whatever the case may be. So that's VA, again, heart and lungs. That one's a little more complicated than VV. You know, VV is, we're only supporting the lungs. So for VV, you must have a functioning heart. Something needs to send the blood to the body, okay?
Yes.
In VV, we're gonna connect to two veins. We're gonna connect the ECMO and we're gonna oxygenate through the venous system. So you need a functioning heart to get that blood into the arterial side.
Please.
And to the tissues. So that, people, is the most important distinction in VV. And if you're gonna remember any takeaway, remember that you need a functioning heart for VV to work. Otherwise, you're just oxygenating the venous system and not doing anything.
Yes.
So I just want to briefly cover that. I might jump in from time to time when Vicky, explains some stuff. But go ahead, Vicky. You can carry on.
That actually is also why we can sometimes go without anticoagulation on the VV.
On the
because
VV, right.
we're kind of shooting it into the lungs, act like a filter for us.
Exactly.
Where if we shoot a clot into a VA patient, it could go straight to their head,
straight to the
or
brain,
their
or to the
kidneys,
coronaries, or wherever.
So good input on why that's important.
Yeah.
Of course, the other risk factors with these patients with clotting and why we do anticoagulation, you're also frequent blood product administration, you are critically ill, you're highly sedated and immobile. ECMO is a non-pulsatile flow.
Yeah, it's continuous, correct.
And of course, just the exposure of the blood to the extracorporeal circuit increases risk for clotting as well.
Right, because what that does is it activates the inflammation. It activates complement, like she was saying, and cytokines, and that will start all this inflammatory process that she just discussed about a few minutes ago. So,
Correct. Okay.
The immune system does not like anything that's not us.
It doesn't.
It doesn't. Okay, anything that is not of our own making, it starts to do crazy things.
This is just a cartoon depiction of our von Willebrand factor. You can see here the long chain that we were talking about attached to a platelet and then attached to the collagen layer in the basement membrane.
Right, yeah.
That is how it's supposed to work.
That's a nice, easy picture to
it is.
understand. I
The
feel
colors.
like they overcomplicate this in a lot
It
of
can
books.
get very complicated. There's A1, A2, like
Yeah, they really break it down. Yeah.
correct. But we just need to know that this structure here can be disrupted, deformed, lysed by the shearing forces in the ECMO circuit. There was this study, Free et al. In 2024, that looked back at more than 23 studies to review how common this was. And it suggested that almost all ECMO patients develop partial or complete loss of von Willebrand factor within hours of the device being implanted, confirming the acquired von Willebrand syndrome. All right, of course, our common sites for bleeding.
The cannula, of
again,
course.
bleeding is the most frequent, most common complication in our ECMO patients for the reasons that we just discussed. Your cannula site, for sure, almost all the time, 37% seems generous.
I was about to say, I think I see it so much more than
feel like-
that. Yeah.
I feel like it's more than that, but I think this is more referring to
Right.
further out from
Okay.
initiation, like maybe
I was
day
like,
2
I
or
don't know
3.
about that number. I feel like it's 67% maybe, or something like. I see it on most of people.
Of course, hemothorax or cardiac tamponade.
Yeah, that makes
Up
sense
to
too.
17%. Ears, nose, and throat, something I've seen quite a bit of as well. Excuse me. Intracranial hemorrhage, thank God, is only 2.2%.
Those are never fun.
Still a lot.
ICH is never fun.
No.
That's an ugly beast.
GI bleed, 19%.
That-
I feel like that should probably be a higher number
I
as
also
well, but
ag-
that's
I also
what I
agree
found.
with that because that also is very common.
And this vascular bleeding, what's difficult to find it by itself. It's
I was wondering,
clumped
what do they
in
mean by
together.
vascular bleeding? Like,
Yes, so they clump it in with vascular complications, and so part of this is going to be that leg ischemia or
Okay.
that sort of thing kind of
Okay,
clumps
okay.
it together. So it was kind of hard to find a specific
Right.
number with the vascular bleeding.
Okay.
So of course you see your cannulas up here. This is during insertion, so definitely going to have bleeding during that.
Yeah, for sure.
For sure. Then the bleeding at the cannula site days and days later is something that's considered a complication, not necessarily directly related to the insertion.
That is an ugly hemothorax blow.
And yes, this is down here, a huge hemothorax.
Huge hemothorax, yeah.
Not a good day.
No.
Okay. So we have a very general description of our patient here, so we don't violate any HIPAA guidelines or
yeah.
identify the patient in any real way.
Sure.
But
Yeah, we'll try to keep it as general as possible.
for
here.
sure, for sure. So this patient had a code situation, required multiple rounds of CPR, was cannulated upon initiation to one of the facilities here in Houston. Of course, was placed on VA ECMO because it
right.
was severe cardiac stunning. I think the EF was somewhere in the neighborhood of 10% at the
Oh,
time,
gosh, yeah.
ballparkish.
Yeah, that's some serious HF.
Okay, the patient age between 55 and 65. I'm trying to keep it pretty loose here. So approximate weight, about 170 pounds, 77 kilos. So a healthy person, middle-aged, code situation. At the time I came on to the case, the patient had already been on ECMO for many weeks. We'd
Okay.
already done the course with all of the pressors. We'd already done, actually was still on Impella at the time.
Oh, okay.
Had also been on CRRT and had since been removed, so that portion had already run its course.
Okay.
Still had a little bit of low dose inotropy going, but otherwise we were working on weaning this patient.
Sure, okay.
ECMO flow was down to about 2.5 when this situation
Oh, that's
came
good.
up.
2.5 and low on inotropes?
Yeah,
Oh,
low on
that's,
inotropes.
That's pretty good.
Minimal vent support, was doing well.
Maintaining a good pressure.
Yes,
Okay,
I
good.
think the EF had come up to about 35.
Oh, yeah, that'll do it. Yeah, that's good enough.
Lungs were still good,
Mhm.
which is key when that heart function kicks
Yeah,
back
yeah,
in.
exactly. And especially when you go on to VA, they get lazy.
Yes.
You know? And then you throw on a vent on top of that, and then they're really lazy.
That whole inflammation process again, all the
Exactly,
blood
exactly.
products, bolusing.
Yeah, so that's
Yeah.
good that the lungs were still working.
So this patient developed a complication that required placement of a drain without being too specific. The drain had been in place for some time, maybe a week and a half, and it was time for the drain to come out. Upon removal of this drain, a vascular injury occurred.
Yeah,
And
I
thus
saw
begins-
that happening right when you said drain. I was like, oh no, what happened? They took it out. That's all that crept into my mind.
Correct.
I was like,
So thus begins our massive
MTP,
hemorrhage.
yeah.
Yes. Okay. So our first signs of pressure, of course, we started having blood pressure dipping in what had already been a pretty stable patient for an ECMO patient. We'd been off pressors for a while, so this was out of the ordinary. Definitely had to start some pressors on this patient for one that hadn't required pressors for quite some time. At this point, we ordered labs and sent labs down, which can take forever when you know something's going wrong.
yeah, sure.
Next problem that we seen with this patient was rhythm problems. We started catching short runs of VTAC.
Mm-hmm.
This patient was otherwise paced, so it was unusual.
So a lot of signs pointing to hypovolemia.
Yes, for sure. And we had that impella in place, so it was probably starting to suck harder in order to get the flow that it
Sure.
was needed. And this patient was previously volume sensitive when it comes to the impella, was already causing some suction problems previously. So the VTAC runs was probably caused by irritation of the impella sitting there with insufficient volume.
Right. Just chugging around.
Chugging around,
Yeah.
giving a little tug.
Yeah.
So, of course, the next thing to follow was the suction alarms on the impella. So we have to start bolusing. Concerns that it was out of position, that sort of thing was what was running through our minds. But almost immediately after that happened, then we start getting chatter on the ECMO circuit. And we started giving albumin boluses to resolve the chatter on the ECMO circuit because
Okay.
we were dropping flows down under a liter, just like that, where it was just catching. Our CVP, I think at this time was 2 or 3,
Oh, wow.
very low.
Wow.
Blood pressures were dipping still.
Oh, no, yeah.
Then we started seeing visible swelling on the patient's right side, and we ordered an X-ray at that time. While we were waiting on the X-ray, the CBC came back, and we had a 5.6 hemoglobin and a
severely
17.
anemic.
Yeah,
Yeah.
17.4. Previous numbers was in the 10 range, so it was a significant drop.
Yeah, that's a huge blood loss.
Correct. At that point, we did order several units of PRBCs, I think 2, maybe 3, and 1 platelet that blood bank was kind of working on. The patients, all of our ECMO patients, keep current crossin types for obvious reasons and the risk of bleeding. It's good to keep them current. Chest X-ray came and showed that complete whiteout
Hemothorax.
of the right chest wall. Correct. Completely whited out. At that point, MTP was ordered.
Yep.
So you can kind of see this not being this patient's particular monitor, of course,
Right.
but we also started getting a decreased in pulse pressure just because we weren't sending enough volume into the heart to begin
Correct.
with. ECMO circuit was carrying everything. Impella was pushing everything it could. I think the CVP is 3, which is pretty close to what we were seeing in that situation.
You got no filling pressure whatsoever.
None at all.
Yeah.
And then, of course, anybody's been on an Impella around you, you are familiar with suction alarms.
Yeah.
Also showing that lower blood pressure.
Oh, yeah.
This one is on P9. We were
Oh,
only
God,
on.
yeah. You're almost cranked all the way up.
Ooh.
Like, you only got one notch above that.
Dang. Yeah. So first thing you would do would turn down the flow a little bit. This one probably isn't somebody that's on ECMO to
Right.
carry the rest of it. I believe we were on like P4 at the time.
Oh, wow.
Yeah. So it's kind of what you would be seeing in there.
Yeah.
So after we got that first round of MTP on board, we were able to get the patient to IR, who went in and attempted to embolize this bleeding. It was thought at the time that they had gotten it. When we got back to the CVICU, we continued having these unstable vital signs, had to keep pushing fluids just to keep the ECMO circuit flowing.
Yeah, sure.
It seemed like the minute I stopped pushing fluids or product, I would get the suction. It would happen within minutes of something completing as far as transfusions and such.
Right.
We actually had to transport to IR with blood going.
Right.
At that point, it was time to call in one of the surgeons. We had one on site, came and put a chest tube in to try and evacuate that residual hemothorax that was in there.
Yeah. Well,
Still kind of thinking the bleeding.
The inflation of the chest,
Yes.
too.
So they were thinking all that blood in there was still causing some problems, plus it had to get washed out. Still thought that the bleeding was fixed by RR, but once the chest tube was placed, we had profuse bleeding coming out into the atrium. We did fill 6 atriums.
Oh,
Six
my
atriums. Plus, he was using suction during the placement of this chest tube, and we filled 5 suction canisters, which it looked a lot like that down there.
God.
We actually clamped the chest tube at one point just to kind of slow it down a little bit, thinking we were possibly to cause a little tamponade effect on it and slow it down a little bit. And of course, we're proceeding with multiple massive transfusion protocols after that. Eventually, our on-site CV surgeon had to be called, and the patient went back to OR to open and repair the vascular defect. Ended up doing a whole washout, and ultimately that's what stabilized the patient. This bleeding definitely was made worse by all of those factors we talked about on the first slide that make ECMO patients so prone for bleeding.
Yep.
In addition to the vascular damage itself. Okay. So massive transfusion protocol, most products were given through the ECMO circuit, as is pretty standard practice.
Sure.
We use what's called a recirc line. I know some places may have bridges or different configurations.
Right.
Ours comes off the top of the oxygenator. So right up here out of the screen just a bit is a positive pressure part of this recirc line.
Yep.
And it circles back around. It looks like it goes this way to the negative side right before the pump, the centrifugal head.
Yep.
So very negative side here, very positive side here. And we can attach the IV tubing as close to the negative side as we can to promote very rapid infusion.
Infusion, correct.
Which can be made
It'll
even...
just get sucked right into the negative side of the cone, and then shot back.
Correct. And it can even be made more negative by turning off one of these stopcocks temporarily just to kind of delete out that positive pressure influence, make it all negative.
Make it all negative.
You can give tons of product very quickly. Okay. Of course, the goal of massive transfusion protocol is kind of to ensure a balanced resuscitation with a transfusion ratio of 1 to 1 to 1, which is plasma to platelets to RBCs. Our facility does 6 RBCs, 6 plasma, and 1 jumbo platelet. 1 jumbo platelet is about 5 units, 5 to 6 units of platelets. So it still stands to the 1-to-1 rule for the most part. And blood bank will send 1 at a time as you need them, and you're just constantly sending people to pick them up as available. Of course, the initial goal being to address the bleeding.
Correct.
Once we get that resolved. But then the rapid infusion of large volume of blood products, if not done with this 1-to-1-to-1, causes that dilutional coagulopathy.
Right, which will just, then you're caught in a vicious
Then you're in that loop again,
right,
for sure.
Yeah.
And other complications, which we're going to discuss here in a moment. Another point, if that I think Joe was going to talk about the cell saver in certain situations, and we have in the past used cell saver in the CVICU for really profusely bleeding patients, which can be counterintuitive because again it washes out all those clotting factors.
You're only left with packed
Correct.
RBCs, and then you're not gonna have that 1-to-1-to-1.
And then you don't. You're
Because
kind of
then you're
just
gonna be too heavy
wasting
on the
all
RBC
your
side.
yellows.
So yeah, it's
Correct. So
I've seen them do that many times.
Yeah.
In massive bleeds, and I always wondered the same thing.
how does it
How does
end
it
up?
work? Like, I get that you're giving back all the red, and that's fine and dandy, but I feel it's the yellow that's more important.
It is.
You know, in that situation, sure, we need red. I'm not saying we don't. But you need it exactly like you said. You need all 3 of them in the balance that exists in the body.
As close to as you can.
As close to as you can. I mean,
Correct.
but just giving red over and over and over again, you will dilute out your everything. And sure, And Cell Saver's the worst type of red, like you said. I mean, like, it's you had it and you washed it away. Like, it was there and you just threw it away in a waste bag.
And
Like,
there it goes.
There it all sits in your little waste bag.
Yep.
Like,
And I've personally seen this situation where they did Cell Saver to the point where blood bank was running out of yellows to give it back.
yeah.
And you just have to cut it off because you're not making any ground.
Right.
Yeah, making the problem much worse.
Yeah, that was exactly what happened in the case that I did. That was the same exact thing.
Same thing.
Yeah, they eventually were like, we have no more yellows to give you.
You keep washing them away.
Yeah, you keep like they're going like you're not even giving them to the patient at this point. But yeah, you're just throwing them in that giant bag. We had like 3 waste bags because obviously one waste bag gets filled. They're only like
Yeah,
10, 12
yeah.
liters, right? So we were filling them up, changing them out, filling them up, emptying them out, changing them out. Oh my God.
Man, we're giving a lot of blood.
Yeah.
Yes. So that is one of the considerations for sure. So things that I was watching, of course, I'm always very cautious of air
Correct.
being introduced into my circuit. I'm always very careful to make sure there's no air in any of my fluid
Yeah.
bags.
That's the name of the game in perfusion, though. At
just-
any point in time, whether it's perfusion or ECMO or anything, air is like our nemesis, right?
is.
That's like the one thing. That's the main thing that you should be looking out for. Air is you should never introduce air. There's never a situation where that's going to be a
That's
good thing.
never good.
It's never good.
So, and especially in a situation like this, it's a high stress. We're moving and switching and
Right.
spiking, and we're moving a lot of things off and on of that ECMO circuit very
Exactly.
rapidly. You have to be super cautious, super diligent, and sometimes they don't push all the air out of them blood bags, and you
No,
do
they
need
don't.
to
You're
burp
right.
it.
You're right.
You just
They
got to
just
be.
spike it and they don't
Yes.
burp it, and they don't realize that you're left with a good like 25, 30 cc's
Yes.
of air inside of a bag.
Yes, so you got to always check that. Another thing that's very dangerous in this situation is those albumin jars,
Oh yeah.
because you're bolusing very rapidly, waiting for the next products to arrive, trying to keep patient volume safe for your ECMO flow. If you turn your head for a moment, that jar does not collapse, and you have a needle making a continuous air tunnel right into your circuit.
Right, yeah.
So just as a rule of thumb, if I'm giving albumin with the jar, I'll keep my hand on it the whole time. And if
And then
I
pop the
turn
needle out
away,
right when they're done.
I will clamp it if I have to turn
Clamp
my
it,
head.
okay, yeah.
I will not release it because I know how quickly and how easily it is to get distracted in that
Yeah.
situation. You got people coming, how many units is that?
Yeah.
So yes, big concerns with air getting introduced into the circuit. Monitoring for clotting, because of course we're giving all of these clotting factors,
Yep.
and perhaps they're doing tranexamic acid or if some other product on the IV line that could cause that issue, Kcentra.
Yeah.
That one always worries me
Yeah.
a little bit, but if you're
Yeah.
hemorrhaging out,
Exactly. Are you really? You have to treat the immediate problem, right? And they always will.
They
If
always
you're hemorrhaging
will.
out, sure, the ECMO is important, but we can at least try to do a change out later. You know what I mean? Like that's what they'll think if he makes it or she makes it or
Yep.
whoever the patient is makes it. You know?
correct. And then, of course, making sure to keep track of my rotation of products, because if I rapidly infuse all these PRBCs, of course, we are making that dilutional coagulopathy
Yep.
worse, and it just reduces the function of all of your coagulation factors and your platelets too. So I'm keeping track of that in my head. I'm closely monitoring my ECMO circuit blood flow, because if by any chance that hemothorax starts exerting too much pressure in there, I could be putting pressure on my cannula and causing me to lose flows for that reason as well.
Yep.
Let's see. Hypothermia,
Oh, yeah.
hypocalcemia, and
Yep.
hypomagnesium. very important things, and sometimes you have to remind people that's in the room that can put in orders and send blood samples for you. I need
Yep.
that calcium. Can we
Yeah.
just give an amp of calcium?
Yeah, I mean, you can give all the clotting factors in the world. If you don't have calcium to activate them,
Correct.
what good will they do, you know?
So for those of you who don't know, or
Yeah.
maybe do know, calcium is actually factor 4
Four, yep.
in your clotting
It
cascade.
is. And
So
it's used at many steps in the clotting
Correct.
cascade as an activator. It's needed as not as an activator, as a cofactor
yes,
to produce the activated forms of those clotting factors when they change from either, 12 to 12A or whatever the case may be.
Yes.
But they're needed for that. So without calcium, your clotting factors are literally worthless.
correct.
They are just you're on all platelets, and that's not gonna do anything. That platelet plug isn't gonna do anything. Why? Because you also don't have von Willebrand factor, right? She had just told us about that, so now your platelets are useless. So you just you
Correct.
got literally no type of anything, no platelet plug, no clotting cascade, no nothing. You just
Nothing.
bleeding.
So yeah, there's several pathways that are intimately involved with calcium in the body in response to hemorrhage, not to mention your cardiac contractility
Yep.
and hemostasis in general. But during bleeding, calcium present in the blood itself is lost in the blood
It
that
is.
is lost.
Yep.
Calcium hemostasis gets disrupted by that. And of course, citrates used to preserve our blood products. It's in the blood bags that blood bank
It
sends
is.
us.
It is.
And citrate chelates calcium,
It does. It
takes it away,
binds it and just takes it away.
reducing it even more.
Yep.
Yes. So you get robbed of your factor 4 in multiple ways, that causing multiple problems and making it very hard to
Yes.
slow down bleeding. Hypothermia as well exacerbates bleeding.
Right.
So this just is a little chart here, kind of
Nice.
showing that sequelae.
Good old. And it's always in a circle. It's the best.
It's always the circle.
Everything our body does, it just loves these circles that will kill you.
Yes.
I don't know why our body does it. This is not the only circle. There's so many other circles, but they're like that. It's like one thing will lead to another, will lead to another, will lead to another, will lead to another. It's like the DIC circle too. You
Yeah,
know,
that one's
it's a
the
circle too. And
negative feedback groups.
Yeah, it's like, man.
God. Okay, and then lastly, I just wanted to address platelets through the circuit.
Oh, okay. Yeah.
There's a lot of
There's that's
beliefs
controversial.
one way or
Yeah.
another on that.
A lot
First
of
of
people
all,
won't do it. They want to give it
Yeah.
at the head. They just won't do it. And
correct. All the platelets are going to go through the circuit anyway.
this is true.
So we're going to disrupt and cause platelet problems just from being on ECMO, no matter where we give the platelets through. The largest concern that I have heard with giving platelets is that it will ruin your oxygenator faster.
I've heard the same thing. I
Yeah.
don't have any real research that it happens, but I've heard that from plenty of people.
Well, I do.
Yay.
Chigandi et al. In 2022 published their
Very
research.
recent.
Yes. They found that there was no effect on oxygenator function when platelets given directly through the ECMO circuit, except with the exception of an already failing oxygenator. An oxygenator whose function had already been diagnosed as
Compromised,
being
sure.
compromised.
Right.
We did see a change in delta P of about 5.2, I believe, with a plus or minus 3 on that. So it could be as high as 8 or 2. They give a plus or minus there. And PaO2 was decreased about 98% after, a 90, minus 98, not 98%.
I was like, dang.
That's a lie.
I was like, that
No.
guy's not going to make it.
Like PaO2 went down,
Down
98
90, okay.
in response immediately after platelets were given. But that was only noted in oxygenators that were already iffy and on the verge of being replaced anyway. So perhaps something already adhesing and clots already in
Sure.
there made the platelets more adhesive.
Yeah, because they'll stick to them.
Yes.
More. The platelets love to stick together. I get that,
They
you you have low one Vilbrand, but the new platelets you're dropping are going to be much more stickier.
Yes.
Than the old platelets that are already in there. So.
And I believe they looked at some 52 different patients on this.
Really?
So not a huge study, but
I'm still
it
glad
gives
that
us
somebody
something.
did it. It helps because again, we have a lot of like, like you said. I've never heard that. It's not even a half and half thing. Most perfusionists will not give platelets into the ECMO. I've only come across a few that are okay with it. Most will be like, at the head.
Yeah.
Like, I don't want it nowhere near me. And what you said just makes perfect sense. Well, it's all coming back to us anyway.
Exactly.
And it's going to come back very quickly.
Well, they're going to give it through their central line, which is right here.
And it goes
my
slow?
cannula
I
is
would
right
imagine
here.
yeah, exactly.
You're
So
probably
it's
just going right
it's
straight through my
probably
circuit
coming-
anyway.
Yeah.
Most of
You
it
think it would
anyway.
be due to the speed, Vicky?
I
mean, when it
know.
goes through the central line, it gets dropped pretty slow. When we
They-
give it through our ECMO,
That's true.
we're
They
about
do
to give
start
it
off
at a
pretty
million
slow
miles
up
per
there.
hour versus the way they takes them hours to get in.
They do.
One,
You're right. Yeah,
I don't know. Maybe I'm just throwing that out there as conjecture. I don't know if that's the case.
Either way.
I give it at the head. I don't know. Again, now that you showed me this, maybe I'll look more into it.
Yeah,
and,
there are
and maybe
some starting to come out, I
be
think.
more objective about it. But I mean, again, I'm still new to the game, so I can only go by what others experiences, right?
I
And
did check ELSO.
What did they say?
They don't touch it.
Of course they don't. Of course they don't.
They said, well, keep platelets between 50,000 and 100,000.
Oh my God. That's not even an answer.
Exactly. So they don't actually have an answer for us. We're relying on these studies, and hopefully we'll get some stronger ones coming out. But I actually give it through the circuit.
You give it through the circuit.
Mm-hmm.
Good for you. Okay. I like that. I mean, like I said, I've only known 3 other people. You're the 4th that does it through the circuit. I like that, though, because it makes sense what you're saying. I've never thought about it that way, that you are right. For me, it's always been about the delivery. That's why I asked it. Is for me, it's about, well, they give it slower. We're about to drop it like it's hot into the circuit.
Ours are in like 3
ours,
minutes.
Ours, they're gonna get their platelets. They get up to their 100,000 in about a few minutes. Versus they do, sometimes they need that, and I think I would entertain the idea. Sometimes, they're sitting at 25, and they'll still drip it nice and slow. Like, dude, this guy's got a
That's
25,000 platelet. You need to let it go, man.
Drop it in.
Drop it in. Your trigger's 50. Like, you're at half of your trigger.
You're going to have to do something.
You got to do something. And then they go so slow that, we run our gases, right? And we run a CBC. Well, when it's that low, I run my CBCs a little faster.
Yeah.
I don't wait their Q2, Q4, whatever they're waiting on. I run one again. And then it'll still be low. Like I'll be like, their platelets are still 35,000. Oh, we only got half the bag, like.
Well, and even those
what are you
IV
doing,
pumps
man?
will only go to 999 for the rate, and
know.
we're dropping them so much faster than even their fastest it'll go.
Maybe I will entertain the idea of putting it in the pump now that I know there's something documented out there that says
There
that it's not
is.
deleterious to our circuit, unless our circuit's already jacked up. But that's
Unless
different.
you're bordering,
Yeah,
you're
unless you're
encouraging
bordering,
abnormal
right.
adhesion, I think. Okay. So our outcomes with this particular patient, again, this is not the patient, it's a stock photo.
Oh, glad you threw that out there. We don't want to get in trouble.
We are hiding all patient
Okay.
information and demographics, sir. So, of course, after this massive transfusion protocol, we were set back an additional week on ECMO for somebody who was about to be decannulated.
Yeah, right. Was about you're already weaning
For
on.
sure. This patient was previously on minimal vent settings and definitely was back on pretty much
Full
max.
ventilatory support. Yeah.
We were on pressor support for an additional 2 days when they previously had not required them.
I mean, were y'all like on full pressor support or still
Yeah,
just
we
kinda
were
low?
still on pretty
like-
significant. We had
Okay.
some levo going and some epi going.
Oh yeah, okay, that's serious.
for a couple more days before we were able to wean those back down.
Okay.
This patient did have
Oh,
a
no.
small left hemispheric stroke
Stroke,
following the
sure.
MTP.
Uh-huh.
We also saw fevers for several days, probably inflammatory response from all the foreign blood products going
Right.
in. But ultimately, a week and a half later, we were able to decannulate. After some time, we were able to wake the patient up, and we found there was very minor deficits from the stroke.
That's lucky, because left hemisphere strokes
correct.
they can be all over the place.
Yes, we were really worried about that. Was our main concern in this period anyway. Once we got past all the more
Yeah.
critical, we were really concerned how this patient would wake up. But fairly minor deficits. Her main deficit actually resolved after a couple days, and was otherwise just a little bit weaker on the one side. This patient did get a trach, and had to be on vent support for several weeks after, but pretty minimal.
Right, and that's to be expected after we take her off ECMO,
For
especially
sure.
when she'd been on that long.
For sure.
Like, or he or she or
Yeah.
I'm just calling she because of the picture.
I know. That's why I keep saying
looking at
she.
that
It's-
picture. Now that picture's become the person in my mind.
that's what's happening here too. Yeah. So it's not this patient, but that's why I keep saying she. We did not have to go back on CRT, which was
Okay.
a big thing.
Oh wow! So the kidneys were good.
This
Good.
patient's kidneys managed to struggle through, and we know that
Wow.
MTP can cause kidney
Oh my
injury
God,
by itself.
I was just about to say that MTP causes kidney injury
Always.
regularly. The kidneys do not like your pressure to fluctuate like that. Okay, they have a window of autoregulation, but they just don't like even going on cardiopulmonary bypass. They don't like that.
No.
And we have very small windows of like low flows or something like that. But even then, you end up with AKI at the end of a pump run. It's
For
just,
sure.
I'm shocked that the kidneys were good.
Plus, there's certain amounts of hemolysis happening with ECMO anyway, but
Yes.
more so with MTP. You get
Yeah.
a certain amount of hemolysis just from foreign blood products.
Absolutely.
And so the kidneys can have a lot of trouble with that. But this patient did not require, and previously had required, but did not have to go back on CRT after this massive transfusion protocol.
Wow, that's beautiful. I can't believe that.
That's the one that shocked me the
that
most.
one, I was just about. I think that one shocked me the most. Like I expected a lot of the ones that I'm seeing up there in your outcome list.
Yeah.
Like I expected
Not
the
to mention
stroke.
just plain volume removal.
Yeah, exactly. I expected the stroke. I think I totally expected the vent. That was for
sure.
I expected the fever. But I also expected some AKI and you to be on
I expect-
CRT. I did
Never-
not expect her or he or she to not be on CRT.
Yeah.
That is crazy.
Pretty impressive kidney beans.
Yeah.
Previously had been injured and managed to get through it.
Yeah. I mean, the patient was on CRT before, right? You said it, and then was able to come off of it?
Correct.
Yeah, that's crazy.
And of course,
Yeah,
need for
PTOT.
extensive
Yeah,
PTOT.
that's for sure, especially given the stroke.
For sure.
Yeah.
For sure. And not even just directly related to the
No,
MTP,
right.
but this patient already been in bed for weeks
Exactly.
on ECMO, so this was
Yeah.
an expected outcome there. Okay. So outcomes after NTP on ECMO. Chin et al. Published their article in 2020, was the most recent one I could find involving massive transfusion protocol on the ECMO patient. There's plenty of them on ECMO patients or on MTP, but the two of them together,
Together.
it's more what we're talking about here. So they looked at 2,757 adult patients who did receive massive blood transfusions during ECMO support. Okay. They found a positive dose-dependent relationship. So the more products they had to receive, the worse their outcomes got.
Which again makes sense.
Dose dependent,
Yeah,
So increased mortality and complications. Definitely, we know that many studies have shown that patients receiving massive blood transfusions have a higher risk of in hospital mortality versus patients on ECMO. You can see the difference here. So 65.6% with the ECMO versus just MTP alone.
52.1.
Correct. All-cause mortality during follow-up, 47 to 35. Of course, we've seen a higher incidence of sepsis post-ECMO, respiratory failure, and then that acute kidney injury for
Can't
sure.
believe the patient didn't have
For
a
sure,
TBI.
always
Wow,
there.
That blows my mind.
And prolonged ECMO and hospital stay for sure. Massive blood transfusion, even without ECMO, is associated
Right.
with longer duration of hospital and ventilator use. With ECMO, you're going to see a longer ECMO use, which we did see with this patient for sure. And longer stays in the ICU. Respiratory failure is another big one, just because that amount of volume combined with whatever heart pathology they have going on already can definitely make respiratory failure a lot worse. So that's the most recent article I found on it. I mean, actually, not as bad a numbers as what I was expecting, but still definitely have that increased risk versus transfusion alone.
Right, yeah.
And that's just all I have. Here's my citations.
Look at that. You have citations.
Always. If I put it in here, I found it somewhere in a research article.
Good for you.
A good research article. Do you have anything to add?
Well, I mean, I kind of was adding it as we went.
Yeah.
I'm blown away by the lack of AKI in that patient. Like the chances of that are, to me, so low. The fact that that much loss of blood, that much transfusions, that much foreign blood. The fact that the kidneys went through that and were able to still stay smiling and happy blows my mind. Because
That's the one that surprised me the most as well.
We can cause it just in a 2-hour bump run. And now all of a sudden they're telling us in ICU, oh, we got to dialyze. Like, what?
Yeah, it really doesn't take long to cause a kidney to get upset.
No, I'm caught off guard by that. But that's great.
Do we have any questions, David?
Magic gave us a thumbs up.
On the chat.
Tell
Thanks,
him, give him a
Magic.
thumbs down for not being here.
Yeah, but where's Magic?
Hey, where is Magic?
He's doing a case.
Oh, okay, then it's fine.
Okay, what's
Fine,
our
Magic,
next?
do your case.
What's our next?
Tomorrow.
Tomorrow, 1900.
Tomorrow at 1900, it will be me with Dr. Bhatia and
Nice.
possibly Joe. I don't know. I'm assuming he has told me he's going to be here, but
He told me he would be here tonight.
I've heard that before. So
This
not putting
man
any
does
stock
so
in
much
that.
clinical stuff. If he's not here, it's for a good reason. He's
Yeah. Oh no. Yeah.
he's
He's
keeping the clinical side together for us.
exactly. He's not just not here because like he's just farting around or something like that. No.
Correct.
He's in some hospital doing something.
All right.
But yeah, so tomorrow we will be doing this at 1900. You will have me for sure. Dr. Bhatia, who has said that he will. I'm not sure if he's going to stop by or if he'll phone in yet, but I believe he spoke with Joe, so Joe has those answers. So everybody, I look forward to seeing you guys. Send us any questions that you have. You can email the email that. Can you pop it on the screen again? Thank you, buddy. So yeah, any questions you got, you can email that. You can email me, Samir Patel, SAMIRPATEL @HET.US. I can answer questions as well, and I want to thank everybody for joining us, and we'll see you tomorrow.
All right.
All
Thank
right,
you so much.
bye-bye.